15th, 2024 City Council Work Session. Thank you for joining us in this hybrid meeting format. For work sessions like this one, where there is no opportunity for public comment, those wishing to access the meeting can do so by watching the live stream available on our website, the broadcast on Comcast Channel 21, or by calling in to one of the phone numbers listed for this meeting on the public webcast and meeting materials web page. And just a little housekeeping note, in case of an emergency, an automated external defibrillator is on the wall there behind the staff, and in the event of our needing to evacuate rapidly, there are doors on that side, on the glass window side, and also the double doors in the back of the room for a hasty retreat if needed. Hopefully not. So with that, I want to thank everyone for joining us, and I call this work session to order, and I'll turn it over directly to the city manager.
Hi, Mayor. Thank you. I wanted to say just a couple of things before I turn this over to our team. I've been sort of both looking forward to, and there was a part of me when I first saw the work session poll dreading this work session, because I knew, like, oh my goodness, how are we going to get all of this information together? And so it's a super impressive amount of work that this team has been working on. I want to give a special thank you to Eve Gray, who's joining us from Lane County. Nice of you to come out on a Monday night, especially one as nice as tonight. I am really looking forward to having this conversation about the system, in part because so many of the things that I hear about when I'm out in the community that people are frustrated with generally come down to this topic, and it's really how are people in our community doing, how are people struggling, and what are some of the, implications of that. I had the opportunity on Friday to do a ride-along in our 911 communications center. So just very freshly was there. And then two things that I would take note of. One were the types of calls coming in and just how much need there is in the community for lots of different levels of service, but in particular when it comes to some of the things we're going to talk about. And then the second piece is, as you listen to the work session and you see how complex everything is and all the different ways people working, that our call takers are actually connecting all of these resources, doing the best job they can to take in a call and make sure they're connecting people to the right place. And I was so impressed. They worked so hard, so many long hours. It was a real treat to be there, and I wasn't there long enough. I was there a couple hours, but I needed to really spend a day, I think, to get a good, solid feel of it. So I'll be heading back, even if they're like, oh no, we thought we were done. So with that, I'm going to turn over to Christy, and she'll introduce the team and our topic for today. Thank you.
Thanks, Sarah. On.
Here we go.
On is good.
There we
Yeah. Just a second, excuse me. I'm actually not responding to emails. I'm trying to log back in. For some reason, my computer decides that it wants to kick me out like every 30 seconds.
Technology wonder.
It is. So the other person I wanted to recognize that's not at the table tonight, but has been helping support this effort, is Josh Bates. He's our LRCS director, and you're going to hear more from Josh in the next month about the youth component that we'll touch on tonight. So we're here today in response to the February 26th work session poll from Councilor Leach and Councilor Zelenka, and it's related to mental health and substance use disorder systems. This evening our focus will be on identifying the key behavioral system stressors and challenges and the initiatives that are addressing these challenges at the federal, state, and local levels. We will wrap up with the next steps that council will be engaged in related to this topic, including additional work sessions and the direction for our state legislative priorities. We began by preparing for this work session. As I mentioned, it was a real learning experience for our team. This isn't a service area that we are deeply embedded in, and we're really grateful that Eve is here tonight to represent that. We began preparing for the work session in March, researching legislative hearings on behavioral health systems in Oregon, gathering information from reports, assessments, and web pages. We formed an internal team and held over a dozen internal meetings across all departments within the city. We met with key staff from the Oregon Health Authority and Lane County. We conducted informational interviews with local service providers such as Emergence, Willamette Family, Pacific Source, and Serenity Lane. Through each and every discussion, we learned a great deal, and the amazing folks that are working to provide these crucial services was really humbling to spend time with them. The behavioral health system is a complex network working to address systemic issues. The agenda item summary document that you received was 14 pages, and it could have easily been 3 times that size to delve into the immensity of this topic. As we begin today, I want to kind of frame this around some themes that you're going to be hearing a lot about. One of those is collaboration and partnership. The other is kind of the massive amount of collaboration, partnerships, systems, and the structure that supports folks that are being impacted by behavioral health illness and issues. And also just how Eugene is responding to this and the innovative ways in which we've been able to do so, and how the community safety payroll tax are helping make a difference with the investments related to this work. As we begin today, we want to recognize first and foremost that behavioral health the behavioral health crisis is a human health situation, and our local response has and will continue to be human-centered. The system to support and treat folks struggling with behavioral health-related illness is not always able to keep pace. In Lane County, just over 3,200 county residents receive treatment annually through the federally qualified health center behavioral health services. Across the system, efforts are being made to meet the growing need. However, the need is vast and the change takes time. A number of city strategic goals under the urgent community needs directly relate to behavioral health, homelessness, and community well-being. Our role as a city, Eugene's role, and the points of interaction that we have with folks is really primarily response-based. There are a lot of contacts that we have in our public spaces, but most of it is driven by a request for a response. And every department in the city is connected to this work and committed to providing compassionate response. Even so, through all of the efforts that we are doing, we are challenged to keep up with the need that there is in response. To provide some context, the most common behavioral-related calls for service are for calling into the CLCC are disorderly subject, disoriented subject, or suicidal subject. Those are specific to behavioral-related health needs. EPT Patrol was dispatched to over 7,900 calls for service from September last year to the same time this year, just for these 3 particular situations. Since 2015, the Eugene Springfield Fire has experienced a 38% increase in calls for service that reflect a 43% in time committed to incidents. Because I know you understand exactly what I'm saying. Of these calls, there has been an 83% increase in behavioral health calls and 141% increase in calls where behavioral health issues was the medic's primary impression. It is important to note that the city service response includes management of public spaces. Alternative responses such as park ambassadors, neighborhood service officers, housing support officers, parks resource officers have been developed to reduce the strain on the traditional aspects of our system. Many of these programs have been implemented in the past 5 years. Aligning the service response with the need has been at the forefront of the community payroll tax investments. Programs such as community court, mental health court, housing support officers, and upstream youth prevention programs were established with the tax. This evening, you will hear a bit more about those programs later on. Homelessness is another critical issue linked to behavioral health in Eugene. We have one of the highest rates per capita of people experiencing homelessness in the U.S. Many of these folks have experienced or are experiencing trauma and further challenged by mental health issues and/or substance use disorder. Efforts to address these issues include crisis intervention teams, programs aimed at reducing homelessness by helping folks get the care and support that they need. The economic burden of behavioral health issues extends beyond the medical treatment costs and includes costs to productivity, the social cost experienced by the community related to untreated conditions. Understanding the impacts to businesses and neighborhoods is a high priority for the City of Eugene. We, along with our partners, seek to alleviate the impacts occurring to community members and the ripple impacts across the community. Today, we'll share more about the issues and the incredible efforts underway to address these systemic needs. So what is behavioral health? One of the things that we wanted to do is kind of ground ourselves in that a little bit. As you will hear throughout this presentation, those two topics that fall under the definition of behavioral health, and we will be utilizing this language moving forward as we talk about the issues. Behavioral health, is, as defined by the Oregon Health Authority, incorporates the aspects of mental health, substance use disorder, and process addictions like problem gambling. Throughout the AIS and in this presentation, we will utilize the acronym BH for behavioral health as a universal description, but at times the predominant issue may be an SUD or mental health. What we are finding is that these two diagnoses are showing up in co-occurring manner and have a good portion of the time. The next series of slides is really just about context setting. What is the experience at the national level, and we'll start diving into the state level as well and to the local level. The personal and societal costs of behavioral health care conditions are well documented. Individuals with mental health conditions and SUDs have significantly more chronic medical conditions, higher hospitalization rates, and higher mortality rates than individuals without behavioral health conditions. In 2020, the Substance Abuse and Mental Health Services Administration, an agency within the U.S. Department of Health and Human Services, reported 1 in 5 adults ages 18 and over, which is about 53 million people, had mental illness, which by 2024 had increased to almost 1 in 4, as seen on the slide, which is more equivalent to about 60 million people. And within this group, about 5.86% experienced severe mental illness. And a lot of the folks that we are encountering with our street response are experiencing severe mental health illness. The percentage of young adults ages 18 to 25 with any mental illness increased from 18.5% in 2008 to 29.4% in 2019. Among adolescents aged 20 to 17 in 2020, 17% had a past year major depressive episode, more than double the percentage in 2010 of 8%, and by 2024, that has increased to 20.7%. Trends in suicide attempts have also been increasing among adolescents at the rate of U.S. adolescents and young adults dying of suicide has reached its highest level in nearly 2 decades, with suicide now the second leading cause of death for people aged 15 to 24 and a half. It's very sad. This next slide demonstrates the prevalence of substance abuse disorders, or SUDs, and continues to impact 17% of the U.S. population. While we can see that SUD impacts roughly 1 in 5 Americans, of those nearly 50 million people, only a quarter are receiving the help that they need. In 2024, over 75% of all adults with an SUD did not receive the treatment that they needed due to the challenges that are facing the healthcare system. This slide refers to mental illnesses and the connection to the criminal justice system. And at times, many of these people are interacting with the system, and it's very, very unfortunate. The personal impact for people in the criminal justice system can be debilitating. And the increase in cases with mental health or SUD nexus are skyrocketing in jails and courts across the country. In fact, just listening to a presentation last week by listening to Clint Riley from Lane County speak, talked about some of the challenges with the folks from Eugene that are have this experience, and they're trying to so desperately support them through services. Here are some key findings. So I want to make sure I share that these are from NAMI, this data that we're reporting on. And these are trends which are dedicated. These trends are also showing up within our special docket that you'll hear about more related to as we talk about municipal court later on in the presentation. One of the major changes is within the workforce. There are 340 people for every one mental health provider in the United States. So getting access to treatment and getting people assistance is a major challenge for the overall system. For context on how Oregon fares related to the rest of the country, Oregon ranks 47th overall across related incidences, up from 50 a year ago. So that's actually a good thing that we're moving from being 50th to 47th in our standings. Specifically, Oregon ranked 49th in the nation for adults with any mental illness and 46th in the nation for adults with substance use disorder. Trends in Oregon have greatly followed the nation, and many indicators show inequities by race and ethnicity. For example, overdose death rates have been particularly high among American Indian or Alaska Native people, 30.5 deaths per 100,000 individuals. Non-Hispanic white people, 26.2 deaths per 100,000 individuals. And for Black people, 24.8 deaths per 100,000 individuals. The coronavirus pandemic may have also exacerbated the behavioral health conditions. Estimates from the Center for Disease Control and Prevention, the CDC, Household Pulse survey suggests that the prevalence of anxiety disorder or depressive disorder among adults in Oregon ranged from a low of 29.9% to a high of 50.2% between April of 2020 and August of 2021. So more locally, this chart speaks to some of the challenges in Lane County. And as an indicator of how mental health and SUD crisis are impacting our local area, the indicator in the table is from our partners at Lane County. During the last point in time count, the PIT count in January of this year, self-reported data of the 2,833 individual adults experiencing homelessness, 913 were sheltered and 1,920 were unsheltered. Of those surveyed, roughly 74% reported a behavioral health-related issue. It is important to recognize that the PIT generally underrepresents the actual size and scope of the current conditions of our homeless population. This slide is a little bit more hopeful, and it shows some trend toward recovery. As we know, intervention does work. And from this 2023 data, the reports on the substance use disorder, over 30 million survey respondents that have experienced a substance use problem or are reporting that 73% say that they are in recovery or are recovered. That's hopeful. Similarly, over 64 million Americans that struggle with a mental health issue, roughly 2/3 report that they are in recovery or have recovered. These success rates were the core takeaway from the interviews conducted with the local recovery partners at Emergence, Willamette Family, and Serenity Lane. Recovery intervention works, and it makes a difference and for countless numbers of people in making their lives better. With that, I'll turn it over to Ethan.
Thanks, Christy. Drink some water. So now that we've seen the challenges and some of the solutions, we're going to focus on what the federal and state government are doing related to these crises and pathways for health. At the federal level, the U.S. Department of Health and Human Services, HHS, has a significant role in implementing and advancing the strategy of the promotion of mental health, resilience, and well-being, treatment of behavioral health, and the support of those who experience and or in recovery from these conditions, along with their families and communities. As you can see from the list of divisions within HHS, it's a massive organization that includes everything from the substance use, so SAMHSA, which Christy had mentioned earlier, to CDC and the FDA. So the HHS budget, and as a large agency for the past few years, has been in the $1.7 trillion level. And the SAMHSA funding has increased from 7.3 to 11.7 in the past 3 fiscal years, billions of dollars of investment. Increased investment is response to the growing gap between the need for behavioral health care and access to care and the far-reaching consequences of these conditions, which was the basis of President Biden's strategy to address the national mental health crisis, which included the 3 pillars of strengthening system capacity, connecting Americans to care, and support Americans by creating healthy environments. Examples of the strategy coming to fruition include in July, as you can see on the slide, 2022, SAMHSA transitioned to the National Suicide Prevention Line from a 10-digit number to 988, which we've all heard about, 24/7 lifeline that provides people in crisis access to trained counselors. They also worked in 2024 budget to include mandatory legislative proposals to improve behavioral health for Medicare and Medicaid beneficiaries, which is really important in that access to care. To help build needed workforce, the FY24 budget expands Medicaid coverage and payment for additional behavioral health professionals. And it also funds research to identify the best evidence-based prevention and treatment efforts for mental health and substance use disorders. And so like $200 million went to NIH to start doing more. As the state's health authority, OHA is responsible for a massive, complex network of health systems and is the principal state recipient of HHS federal funding. Their current strategic goal is eliminate health inequities in Oregon by 2030. With an emphasis on transforming behavioral health, build a behavioral health system that works for every child, teen, adult, and family experiencing mental health, illness or harmful substance use by expanding integrated, coordinated, and culturally responsive behavioral health services when and where people need them, guided by people with lived experience. So very great policy goals and vision across the federal and the state landscape. Of note, OHA houses the Office of Behavioral Health Services, which focuses on Medicaid and non-Medicaid funded community-based behavioral health program development, operations, policy, and special projects. So the thematic areas of the Office of Behavioral Health is provided on this slide, and there are a number of key programs that comprise the services to deliver on these themes. So there's the adult behavioral health services, and it's important just to lay out this so that you all understand, like, it's a beast. When I was doing interviews with folks, the words that kept on coming up is massive, complex, unruly, wow. I mean, so it's something that is, and I think Eve and others in the healthcare profession will readily testify that. So in the behavioral health world in OHA is adult behavioral health services, which consist of addiction services, adult mental health, intensive services, and Measure 110 units. Additionally, there's adult mental health services, which promotes the health and well-being and safety of organs over 18 living with mental health issues. There's also Behavioral Health Administration. It's comprised of the Behavioral Health Director's Office, Behavioral Health Equity and Community Partnership Unit, Office of Recovery and Resilience, and Behavioral Health Tribal Liaison. So I think of note, it's important to recognize that they have an Equity and Community Partnership Unit, and that leads their efforts to reduce disparities in behavioral health services across populations, including a Behavioral Health Metrics and Committee and the Workforce Unit, which was created by the legislature to increase recruitment and retention of behavioral health providers who are people of color, tribal community members, or residents of rural states in this, rural areas in the states. Additionally, there's an Office of Recovery and Resilience, and it's a team of policy and program analysts who have lived experience with behavioral health needs. So it's really, I mean, OHA is actually walking the talk and related to access and equity and ensuring that their efforts are responsive to the community needs. There's also the Behavioral Health Strategic Unit, Operations Unit, so they do a lot of policy work. There's a Behavioral Health Medicaid Policy and Planning, more policy and more planning work. There's a Behavioral Health Services, and they administer and fund, and this is child and family behavioral health services for Oregonians 0 to 25 and their families. System of Care Advisory Council, and it's an independent body that reviews a lot of the OHA work and coordinates across various departments and agencies across the state. And then lastly, the Licensing and Certification Unit, which they do licensing, certification, and oversight of over 1,100 behavioral health providers across the state. So it's there's a lot of work going on there. Next one. Next slides are just really quickly showcase where Oregon is relative to other states in expenditures. And so here's where we sit among one of the top states for expenditure per client. Okay, so there's money going per client on out. Next one. Here we are in the middle of the pack related to expenditures per capita. So higher than any adjacent state though, right? And so when people say, oh, what is Oregon doing? Well, we're actually expending a good amount of money. Next. While total population is small compared to other states, we're spending a larger total amount than more populous states. And so once again, we're putting money on into the system. Next, last one. And again, compared to our neighbors, the state's investments are reaching a higher number of Oregonians. Takeaway from these 4 slides to show that the state of Oregon is investing substantial resources to address mental health crisis, and yet we are still facing it. So in your packet, in the slides, there's a fold out of this document here. And so in addressing the behavioral health crisis, it's a top priority for Governor Kotek. It's one of her top 3 priorities, as well as addressing unhoused crisis. In 2023, she convened a behavioral health symposium of experts from across the state to identify focal areas, which included workforce development, care coordination, day services and drop-in care, civil commitment and treatment and housing. So this roadmap was created to illustrate where the state currently is at the left side of the screen and the investments and efforts of state and local agencies and partners in the middle part of the screen to a future integrated system delivering on healthy people and community outcomes. The circled areas are where City of Eugene programs are active, and we did add an additional one of justice component as well, because that was not included, and we think that that's a really, really key component. From here, though, we're going to focus in on 2 areas of the strategic areas for 2025, which are 1, treatment bed capacity, and 2, workforce development. Next one. So in this slide, and this was from the 23-25 biennium, OHA identified previous efforts to address their treatment bed capacity, and here they were on pace to deliver another 1,100, just over 1,100 treatment beds during that 2-year period. Next one. By the end of the 23 session, Governor Kotek had directed OHA to conduct a study on behavioral health bed capacity needs in Oregon, which culminated in a development of a 5-year plan to expand capacity across the state. And so OHA was presenting this in September at Legislative Days. And as you can tell, the report identified the current capacity and future bed need for inpatient psychiatric mental health and residential treatment, SUD residential treatment, and withdrawal management. This does not include the increase in beds at the state hospital or for psychiatric care, and there's a need for an additional 3,200 beds statewide with an estimated $835 million. It's allocated across 5 years. That's $167 million per year. Not something that the legislature generally puts out on a year-by-year basis over the course of time. So it's a very large number. And then additionally, when talking with local partners, there's folks have shared that they feel like this was an undercount. So, next one. And then just geographically, there's trauma system areas within the state. Within the one that Lane County sits in, there's an identified need of 506 beds. Next. And then moving on to the workforce development. So on the right side of the screen, there's a list of identified needs within the workforce area, and this was one of the items that had been highlighted within the work session poll. So we wanted to really try to articulate that, and it's something that the legislature, in my conversations with the speaker, just checking in with her, she had said, yes, when next year in the long session, we're really going to focus in on the behavioral health workforce. So, but just as a background, in 2021, the legislature passed a series of workforce bills related to studies, policies, and funding. And it included House Bill 2086, which directed OHA to study the workforce, and there was a report, and it identifies all of those gaps that are showed there. Additionally, though, in HB 2949 provided $80 million for workforce recruitment and retention. And again, I asked some of our partners, hey, how is that going? I said, yeah, it was okay. It was like a flash of money, and then it was gone. And we still need more. And there was also a whole lot of dynamics related to pricing for workforce and public workforce, nonprofit workforce that then is enticed to head on out into the public or into the private sector, and we lose people. And so the workforce issue in and of itself is an enigma wrapped in a riddle and very complex and challenging. So, kind of moving on, next slide, we'll keep going. So this is their, the OHA's agency request budget, the ARB, to the governor. And so the governor's office will take that and put it on into the GRB, the governor's recommended budget. And so some of the highlights here is that there's $176 million to expand residential treatments, treatment beds across the state, $117 million to sustain, strengthen, and expand the behavioral health workforce, $36 million to expand Save Lives Org and harm reduction, and that's clearinghouse and treatment innovation pilots to combat overdose. That's a lot of naloxone that's put on out. $47 million to sustain and expand Medicaid's certified community behavioral health clinics, and they integrate behavioral health and physical care. Another $36 million to expand access to behavioral health treatment for adults on Medicaid, and then $17 million to increase behavioral health services for students. So that wraps up kind of this federal state piece, and now I'm going to turn it on over to Eve to jump into Lane County's piece.
Thank you, and excellent job. It must have been a lot of research to put all of that together because it is a really, really complex system. So that was a very nice summary. Thank you. I am Eve Gray, Director of Health and Human Services for Lane County, and one of the divisions that I oversee is the Behavioral Health Division. Within the Behavioral Health Division, we have our community mental health program, which is run by our CMHP, our community mental health provider. That position is filled by Dr. Pauline Gishohi, and she is working to fulfill the County Board of Commissioners' responsibility as the local mental health authority within the county. So as the CMHP, we receive state funding in order to do a number of actions and services that are mandated to the state, usually through the legislature. They delegate their responsibility to us through contract in order to perform certain functions. So some of these are functions related to civil commitment, aid and assist, and other systems that don't receive Medicaid funding. Some of it is helping to support individuals who are uninsured. So we support organizations like Peace Health and other community nonprofit providers who are providing behavioral health services to individuals and not being compensated for that care. We also provide a number of clinical services. So it's our job to monitor the system within Lane County, to create assessments related to where we are and what we need to do to close the behavioral health gap, and then to work with the state, because really in this function as a CMHP or even as the local mental health authority, we are an administrative arm of the state government largely. Although, of course, we do receive federal dollars also from Medicaid billing, we receive very little in terms of local reimbursement for our behavioral health services. Next slide. So this is a list of the services that we provide internal to Lane County. You can see that we have a number of clinical programs, which includes adult outpatient programs. Those our programs are really restricted to the individuals who have the most severe mental illness in our community. That is largely related to workforce challenges, which were well covered by Ethan. We have a child and adolescent program. We work both in the clinic and in the schools to take care of kids in our community. That is a more diverse range in terms of how, what we would call acute or how sick people are. Our forensic services are for individuals who are criminally involved and who have a diagnosis of a mental illness. Often that is the aid and assist population, so the individuals who cannot stand trial due to inability to understand their charges and participate in the process. So it is our job to restore them to be able to participate in that process. We also have an opioid treatment center in our Lane County Treatment Center. And we have a mental health crisis line. We just, as I think you all know, launched Lane County Mobile Crisis Response Services to meet the state mandated requirements around mobile crisis response countywide. And we also have adult protective services, so anyone who's in a potentially abusive situation and they're receiving care related to their mental illness, we would perform those investigations. We also do a lot of work for the CCOs in case management of individuals who are on Medicaid and also have a behavioral health diagnosis. You can see our budget there. You can also see that our resources are smaller than our expenses. We are spending reserves right now. That is not sustainable for us in the long term, but that is what we are doing today to try and maintain services in a resource-poor environment. Next slide. So changes for this year, I mentioned mobile crisis services. We are providing them for adults. We are continuing our collaboration with Riverview to do the youth portion of mobile crisis response. And there is one other mobile crisis provider funded through us in the county, and that is Western Lane. To serve the Florence and Mapleton area. We also have been doing some work on a community navigator pilot program that the state asked us to do around the aid and assist population with the Mossman order, which I think you all also are probably familiar with, and the mandated timelines where people need to be released from the state hospital, whether they are restored or not, and then needing to provide services to these individuals who may still really qualify for a hospital level of care, but we are expected to provide services for them as outpatients, which is another real challenge that we face. Next slide. Okay, so a couple of things on this slide that I will highlight. Mobile crisis can answer any questions on that, certainly have talked about it. Medication-assisted treatment, we're looking to expand to the rural areas, not as applicable, of course, to Eugene. The Crisis and Stabilization Center, I don't know how many of you saw, we had a pretty big announcement today in collaboration with Peace Health, and Alicia Beamer has been kind enough to join us in the audience in case you have any questions on the Peace Health portion of this. But we are looking to jointly acquire property in Springfield where Peace Health will build a 96-bed inpatient behavioral health facility that will include 24 of those beds for youth, and our stabilization center, which will have 14 recliners in an observation unit, 16 secure residential beds for folks who can't be stabilized within 23 hours, and 12 beds for youth will be built right next door. So that we are looking at a 3-year timeline to completion for those facilities, which will be a massive increase in access to behavioral health care for individuals who need it, who need a high level of care or just need immediate access to care. In addition to that, though not run by Health and Human Services, the county is starting a deflection program. So that is being run out of the Parole and Probation Department. But this is for individuals who are committing crimes and law enforcement, and either that crime is that they are in possession of a substance, or it is a low-level crime that an officer believes is primarily related to substance abuse. And there are certain crimes, I would need to get the list for you if you want it, but there are certain crimes that are defined, have been defined by our district attorney that would be appropriate for deflection. So at the point where an officer may cite or arrest an individual, they can offer that individual an alternative pathway. They can deflect them from any engagement in the criminal justice system. And if the person agrees to participate, they will be followed up with a peer navigator the next day, which then can bring them through a process of case management. If you actually, I think it's 2 slides maybe that that the full system is described for deflection, but we will get to that in more detail. Thank you. Either way. We can talk about this one. No, it's all good. I realized that in my talking I went more to deflection, so it's good. We can go here and then hop back. So you can see here what the process and the pathway will be for deflection at this point. Someone who enters into recovery and successfully moves through the process. It may not mean complete abstinence, but it does mean the individual is engaged in their recovery and not continuing to be involved with the criminal justice system. And if after a period of time, and I think they may still be defining the exact timeline, the individual is successful, charges will never be brought. So the charges are essentially held in abeyance for people who participate in the deflection program. This is different from diversion, which is what we see in treatment courts, where someone is arrested, they might be booked, they enter into the criminal justice system, and then they enter into a treatment court after they've already gone down the criminal pathway. This deflects them before anything criminal starts. And if you want to go back one slide, that's perfect. Thank you. Yes. So the burns, another initiative funded by the state of Oregon. Lane County does not have a burn that we run, but there are 3 burns, behavioral health resource networks in Lane County that are run by conglomerates of nonprofit agencies. And you can see here the types of services they provide. These are marijuana dollars that had been coming to local jurisdictions, were reallocated into a number of resources from peer support and housing services to harm reduction, screening, and assessment. You can see there's not a lot of treatment that is funded through the burns. They are expected to provide rapid access to treatment, but the rationale that OHA had is that Medicaid funds treatment, so they wanted the marijuana, the Measure 110 dollars to be funding other parts of the system. I think that we've identified, and OHA has identified, that we don't have enough treatment. So it wasn't enough just to do all of these other pieces, which is what you're seeing in some of the other investments that OHA is proposing for this next session. So I think that might be it.
Thank you, Eve. It's so great to have you here tonight. So I don't know if anybody wants to stand up, shake it out a little bit, but we'll keep going if you're ready to move on. So our next slide, please. Our next and almost last section of the presentation focuses on Eugene-specific programs. You'll notice that we have the Eugene Public Safety Payroll Tax as logo on the slides. One of the things I wanted to call out is that you'll hear us talk about either the programs are fully funded, partially funded, or receiving some one-time dollars as part of their service implementation. And so I just wanted to call that out because our community safety, public safety tax dollars are hard at work in really trying to address these problems. Next slide, please. So EPD, as you know, plays a significant role in delivering behavioral health services across the city, going beyond the traditional law enforcement responsibilities to address the growing needs of individuals experiencing mental health challenges and substance use disorders. In an earlier slide, I referenced the volume of calls for services related to the top 3 most common behavioral-related issues. It is important to note that Central Lane Communication staff, as Sarah alluded to earlier, is responsible for 911 call taking and triaging and for dispatching units from EPD, Eugene Springfield Fire, and Cahoots. They dispatched over 80,500 calls. They took in 80,500 calls in a very one-year time period, which is an incredible amount of work. In addition to that, there were 14,500 that were processed for Cahoots response. This team does an incredible amount of work, and they are really a critical point in the system in which everything kind of pushes and pulls through. As behavioral health issues continue to influence public safety concerns, EPD has adapted its approach to ensure an effective response to these complex calls. Traditional police services are rooted in enforcing laws, maintaining order, but an increasing number of requests for police services involve behavioral health-related components. In recent years, EPD incorporated behavioral health-related features. In recent years, EPD has incorporated behavioral health-related features into new and innovative policing services that extend beyond the traditional ones provided by law enforcement. EPD has long recognized that the traditional law enforcement model alone is not always the most effective response to issues rooted in mental health or co-occurring substance use disorders. The programs listed under innovation section of the slide reflect more of an informed approach, advancing the way that we do our work. The goal is to reduce, to provide immediate response to the safety needs of the individual and surrounding area, and also reduce recidivism among people that are experiencing mental health behavioral crisis. Lastly, EPD continues to shape a policing model that balances enforcement with care and is actively involved in the development and expansion of programmatic areas focused on diverting individuals with behavioral health issues away from the criminal justice system and toward treatment and support services. Eve shared a bit about Lane County's efforts related to the Deflection and the Stabilization Center, which provide an opportunity to share more about the co-responder program. Next slide, please. So I also wanted to say that in your agenda item summary packet, there were also attachments, and some of the attachment go into a lot more detail about some of the programs that we're going to touch on, and you will also get more detail on November 25th when we have a panel discussion that includes the two chiefs, the municipal judge, and a couple of other staff members from our team. So a cornerstone of EPD's innovation approach is its downtown co-responder program launched in April of this year. It was initially started with community safety dollars with a $200,000 investment. The program pairs a qualified mental health professional, QMHP, from Lane County Behavioral Health with a downtown police officer. The co-responder partnership allows both behavioral health and criminal factors to be addressed simultaneously during calls for service. For example, when responding to an incident involving someone exhibiting a behavioral health issue, the co-responder team can assess both the individual's legal situation and their need for mental health support, ensuring that the response is safe, compassionate, and comprehensive to meet the subject's immediate needs. And we really appreciate the partnership with Lane County in providing this service. It's been absolutely amazing. The co-responder team engages with individuals facing a range of mental health diagnoses, each of which can complicate their interactions with the criminal justice system. Data on access to behavioral health resources collected by the co-responder team show that nearly all of the subjects screened were not currently accessing any behavioral health resources. And of those not receiving services, 53% were not interested in enrolling in LCBH, Lane County Behavioral Health Forensic, and the FIT team, to be participating in the FIT team, Forensic Intensive Treatment Team. Additionally, EPD was awarded the U.S. Bureau of Justice Assistance FY23 Connect and Protect grant, which will increase the program by $550,000 and allow for expansion of the program that has been established. Both co-responder teams will be under the leadership of the Downtown Incident Commander, who coordinates the effort to maintain the downtown and to keep it safe for everybody, but mostly to help people who are needing to be receiving more support, that we're making those connections with them personally. Next slide, please. The Eugene Springfield Fire Department is customarily one of the primary responders in calls regarding behavioral health and substance abuse incidents, and is typically the first to provide medical care and sometimes life-saving care for these individuals. Traditionally, these calls have been responded to by a large engine, ladder truck companies, and ambulance. To maximize staffing, most firefighters are also trained paramedics. I believe they all are, actually. ESF looked at reshaping the way the department responds to calls after a broad evaluation of services in an effort to minimize efficiency. Community safety payroll tax funding has been instrumental in making this transition, with $1.3 million in FY23 the payroll tax budget to support the implementation of a fully tiered ambulance transportation support system, including 3 new ambulances and hiring of 5.0 FTE for advanced life support tech paramedics. With the implementation of these changes to services provided by ESF, we have been able to relieve the burden on the larger units having to respond to low acuity calls, allowing them to focus on fires and those higher acuity calls. Additional information can also be found in your AIS with the attachment specific to the fire services. So this next slide will look a little bit familiar. It's similar to the one that Chief Heppel presented on September 11th. And during that presentation, one of the things that he stressed was the emphasis that they have placed on developing alternative response programs. The objective of alternative response is to provide timely and appropriate medical care to individuals in need, focusing on situations where traditional emergency services may not immediately be available or suitable, depending on what is happening for the individual. This program aims to ensure efficient deployment of resources paired with collaboration and integration of current healthcare system services to enhance overall community health and well-being. Alternative response methods to pre- and active 911 calls are quickly evolving in both rural and urban areas. Emergency medical services providers, EMS providers, and healthcare systems look to reduce the use of EMS services for non-emergent 911 calls. In urban areas, programs which include medical providers, community paramedics, community healthcare workers, social workers, and behavioral health specialists, and nonprofit organizations have demonstrated success in and out of the facility or clinical environment. Additionally, these services can help fill gaps in the facility clinical healthcare delivery service system. So this diagram shows all the different ways in which they're either engaging or moving to engage in more alternative response strategies. And much of that is in partnership with Peace Health and also with Lane County, which we very much appreciate. Next slide, please. Eugene Municipal Court operations have expanded in recent years, supported in part by investment of the community safety payroll tax also. It is estimated that over 50% of the cases processed by the court have a nexus with a behavioral health or substance use disorder issue, with over 70% of the violations and misdemeanors processed by the court having a behavioral health and or a SUD component. The community safety payroll tax funded programs have stabilized services for a system that has historically been stressed and allowed for expansion of specialized programs such as community court and mental health court. These programs or court sessions are designed to address the unique needs and challenges of the Eugene community, each having some component of robust case management, engagement with service providers, and attempts at off-ramps outside of the traditional system. Historically, city prosecutors have been a mix of contract and regular employees and staff stabilization, and the staff stabilization efforts to really streamline the docket and to make sure that the system is flowing freely. The investments within the system related to adding more capacity to the prosecutors, judicial services, and staff has been absolutely valuable, and especially as the court is responding to greater needs of the people that they're serving. So the next slide is really the specialty docket unit. Eugene Municipal Court has been at the forefront of innovation practices for a number of years, most notably with the development of the specialty docket unit, which is a team of staff dedicated to coordinating cases across special docket programs of community court, mental health court, and opportunity docket, the 370 docket, and the Oregon State Hospital docket. So there's, as you can tell, there's a lot of different things happening at the court where there's a lot of interaction with people that are needing connection to services. The SDU is, the specialty docket is made up of dedicated specialty team that includes 3 dedicated judges, 2 dedicated prosecutors, attorneys, and law enforcement officers. The intention is to really have a wraparound program that is helping support the individuals in need. For a 2-year period of 2022 to 2024, there were 9,277 misdemeanor charges, and of those, 1,178 had a program code added to their cases that tied to an SDU or a specialty docket, roughly equaling 12% of all of the cases, which is pretty darn significant when you think about the volume of people that are coming through court. Having worked in the court for a number of years, one of the things that we always found most rewarding was being able to help get those folks connected to services. And it is very awesome to see the efforts that the court is putting into these specialty dockets to be able to have a more high-touch interaction with people to help them get connected. In the fall of 2022, the court received a BJA grant for a community court expansion. The amount of $600,000, that was also matched with $200,000 of community safety payroll funds. The expansion grant has allowed the court to expand their high-risk track, partner with the Laurel Hill Center and community supportive shelters to provide greeter service and stable shelter. Laurel Hill Center provides mental health and substance use disorder services, including partnering with local SUD service provider Emergence and services that include housing, employment, skills, and other services. Community supportive shelters provide a shelter site with individual huts for community court participants. The site has 16 huts and includes case management and works with participants to move them through the sheltering system. In March of 2024, the Center for Justice Innovation, in partnership with the Bureau of Justice Assistance and Eugene Municipal Court, hosted a community court regional convening in Eugene. The convening was a space to share best practices and emerging innovations, build relationships, and identify resources within the region. They welcomed all types of community court collaborators, including judges, prosecutors, court coordinators, public defenders, law enforcement, case managers, and community partners. Courts from all over the United States came to attend and participate in this event. Next slide, please. So the core element of the city's unhoused response efforts continues to be to provide safe and secure shelter. Eugene is currently limited in the number of shelter spaces available for people experiencing homelessness, with roughly 3,500 people in our city unhoused and about 1,000 shelter spaces. To help address this critical need, the city supports a diverse set of shelter options, working with partnerships with local social service providers to increase stability and safety for individuals experiencing homelessness. These options include vehicle or safe parking sites, non-congregate village-style sites, and congregate shelters. One of the key points that we're trying to make on and share with you is that the systems that we're setting up are really focused on, again, providing a safe place for people to be and also have a chance to get connected to services. And so we're working with a variety of service partners to be able to do that, and we're finding that the success rates have been very high. Again, getting people stabilized, helping them get back on their feet is the goal of helping through these shelters. The next slide, please. The next slide is really an indicator of all the different service partners that we're working with to help connect people to services. One of the ones that you hear us talk about quite a bit is the 15th Night, and that's a youth-related service, and you'll hear Josh Bates talk about that more when he does his presentation in November. In fiscal year 2004, 55% of those served in city-supported shelters were chronically homeless, and 59% of people self-reported having a mental health disorder. So we know that helping them get stabilized in those shelters will do exactly what we're trying to do, which is achieve better outcomes. While increasing shelter capacity has been an essential part of the city's strategy, supportive services are also an important part of increasing stability and access to housing for individuals. A key city innovation has been the investment in coordination and partnerships to ensure that supportive services are offered within the city's supported shelter programs. This investment continues to build out supportive services and resource connection offered to those people living in the shelters and increase stability and relieve human suffering. Next slide, please. This next slide is just a brief overview of some of the work that's happening related to youth intervention and prevention, and primarily that work is happening in our Library, Recreation, and Cultural Services Department. They've been placing an emphasis on addressing behavioral health issues and is centered on responding to those seeking shelter and services from the library and in an intervention-style inclusion support program for youth. Each year, the city, schools, and area programs see an increase in requests for inclusion support. The inclusion staff respond to those requests by creating individualized support plans that enable youth to fully participate in recreational activities. Through the Inclusion Services Program, parents, caregivers, and youth workers with the Inclusion Services Coordinator create environment support plans for children with developmental, health, and behavioral needs to help them participate in summer camps and recreational activities. The Youth and Family Services section of the Recreation Division provides multiple opportunities through recreation programs to support youth, organization, and individual participants to engage in learning, exploring, growing, and contributing to the community through workforce preparation, leadership training, outdoor adventures, building social skills, and art making. The program created for youth empowerment programs intentionally serve historically marginalized groups. Recreation programs serve as preventative intervention, offering enriching and supportive environments where youth can explore, be safe, and build essential life skills, ultimately curbing negative behavioral outcomes. Multiple aspects of recreational programs have been shown to correlate better outcomes for youth, and that's really the focus of these programs, and you'll hear a lot more about that when Joshua comes back to talk with you. Next slide, please. Last program slide focuses on our public space team. It's one that you all are very familiar with. We've talked a lot with you about the funding needs related to these services. The public space team includes neighborhood services officers, park safety team, the parks ambassadors, the illicit activities cleanup team, and park resource officers. These teams focus on human engagement and connecting people to services in a compassionate and accountable manner. They work to ensure that public spaces are safe and usable for the entire community. Many times when all of the other engagements and innovations that we have discussed previously are not working, this team is the one that's interfacing and helping people find services and stability. The team is made up of 3 work teams and was developed to engage visitors related to park rules, ensure compliance with park rules, provide resource information to people experiencing homelessness, and clean up after illicit activity in parks and natural areas. This work has been funded by the 2018 and 23 Parks and Levies, and which helped create the Park Watch tool, which is available for public to report issues to park ambassadors and illicit activity team members. Next slide. One of the other requests related to the work session poll had to do with the opioid fund. So since July 2021, the state of Oregon has reached agreement on national lawsuits against several companies for their role in the opioid crisis. Through these agreements, nearly $600 million will be awarded to Oregon over the course of 18 years. These funds can be used for a wide variety of opioid prevention, treatment, and recovery strategies. Settlement funds from opioid manufacturers, distributors, and pharmacies are divided between the state at 45% and local jurisdictions at 55%, pursuant to Oregon's intrastate allocation agreements. The City of Eugene created an opioid settlement reserve to receive distributions from the state. Although the funds continue to be distributed to the city via these settlements, projections show that initial distributions will be the largest, and there may be some variability as to when these funds are actually received in future years. Opioid settlement funds are restricted for very specific purposes per the use of the settlement agreement, and staff must report to the Department of Justice on how the funds have been spent each fiscal year. As part of the 2023-25 biennial budget, opioid funds are planned to be used for the medication assistant treatment. Eve referred to that from another area, but this would be local. Rest stops, vehicle camping, and the purchase of Narcan that's been used pretty heavily over the last few years. Okay. I think we're, okay, next slide. So you have a number of intergovernmental relation topics coming up. On November 6th, the IGR committee meeting, state priority refinement discussion. November 13th, the Eugene Youth Opportunities and Challenges Council work session by Joshua Bates. On November 25th, there'll be a second behavioral, it's hard to believe that you're going to get another one, I know. But the second session that you're going to have is actually going to be a panel discussion with the 2 police chiefs, Judge Gill, Joshua Bates, and perhaps another key staff person to help answer your questions. They're going to talk about the gaps within the system, give you more details that you found in the AIS attachments, and give you a chance to learn about their gaps, their needs, and ask them questions directly. And then you'll have an IGR committee meeting on December 4th to finalize the state priorities, and on December 9th or 11th, IGR priorities will be a council work session discussion. And gosh, I'm sorry, that's all we have today. And so, yeah. Thank you for hanging in there with us. Mayor, I'll turn it back over to you, and we'll do our best to answer your questions. Thank you.
Yeah, thank you. Thank you so much. This was really a tour de force, this presentation and packet, and we really appreciate how exhaustive it was and how deep it was. And I think as we try to keep in mind what all these different pieces are, it was just incredibly valuable to have it laid out. It's a document we can return to over and over again. So thank you for laying it out for us and presenting it so clearly. I have Alan, then Randy, then Lindsay so far in my queue. So Alan and then Matt. Mike.
We knew it
Microphone.
was a tough ask.
Alan, microphone.
It's on,
Oh.
folks. It's on. We knew it would be a tough ask to describe the mental health and substance abuse system in Oregon and Eugene. And thanks for all this work you did on this. It is a tremendous amount of work. And thanks to all the providers that do all this work. It's amazing work that you all do. And very, very much needed in our community, obviously, from all these stats and stories that we hear. We wanted to put this work session forward because I constantly hear from folks, what are we doing about mental health and substance abuse in the city, in Eugene? And more specifically, what's the city doing? And it's a very unsatisfying and very unsatisfactory answer to say, well, you know, the city's role isn't that great and it's pretty limited. Even though that's true, that the responsibility of addressing all of this stuff really falls on the county and the state, it's not a very satisfying answer. So I wanted to put this work session poll forward to inform us about this issue, but also educate citizens of Eugene about what's going on in Eugene and the surrounding areas in the county and in the state, but also how bad all of this is. I mean, it is kind of a depressing presentation, but how does this impact our daily lives? And we see it in our lives, in the livability. I've often said that homelessness is the symptom. What the core problem is substance abuse, mental health abuse, or mental health illness, and lack of affordable housing. Those three things are really hard baked into our system for decades. And hopefully, when we get a better understanding of how this system works, and how and who's responsible for what, and what the magnitude of the challenges are that are in front of us, and that the city's role is actually very limited in this. It's mostly just responsive to all this stuff. All this shows, really, all this information that we got really shows what happens when, as a society, we have neglected this for decades. And problems keep coming back up, and unless we handle these issues of substance abuse, mental health services, and affordable housing, we are never going to solve the homelessness problem in Eugene. There's a lot happening, yet the problem persists, and actually it seems to be getting worse. So I hope this sets the stage for our 25th session, where we have a panel of certified smart people where we talk about solutions, and I'll need a second.
Okay, thank you. Randy and then Lindsay.
Thank you, Mayor, and thank you, Christy and panel, for being here today to talk about this. And also thank you, Alan and Lindsay, for the work session poll. This is incredibly important that we talk about this. You did answer a lot of my questions. I had a whole line of questioning around youth, which I still think is, I hate to call it an afterthought, but I don't think we have enough robust services for our youth, and that's the best way to prevent people from entering the pipeline of the service. I know we're short on beds for them, and I do appreciate 15th Night. I appreciate Looking Glass. I appreciate a startup that's happening right now trying to get off the ground called Scorpion Ranch, organized by Katie Brown, that's trying to provide respite and housing for unattached homeless youth, which I think is incredibly important. A question I do have, drawing back on my years as a firefighter here in this community, of the 85,000 plus CLCC calls for service that fall in these categories, how many of those are repeats? Repeat person. patient?
That's an excellent question, and with all the information that I was able to share tonight, I do not have an answer for you to that, but we will find out.
The reason that's important, and again, drawing back on my experience, I know if you take the top 20 system users out of the system, it makes a noticeable difference. And I very much appreciate the work with Lane County and Peace Health on what you're putting together. That is going to make a difference for us as well. For too long, we've had, one door. From fire and EMS, police have had two doors, basically, they could transport to. And this will give us that important third door that's probably a more appropriate service level. I had a line of questioning around specialty court and restorative justice. I just met with Judge Gill on Friday, and we had a good discussion about this. And I really look forward of having the good judge in as part of this discussion, because he is part of our solution set in how we get there and how we more efficiently use our resources, which really is where we're going to be making forward progress. I mean, there's only so much we can do. There's only so much the responders can do. There's only so much Eve, you and your talented staff can do with limited resources. So we've got to find ways to squeeze efficiencies out of this system, or we're never going to get where we need to be. But again, I think the key is getting back further in the pipeline and trying to treat affected kids before they actually get to the point of becoming broken adults. And they deserve that. They aren't in these conditions usually by anything they've done. So I'll tell you, my heart goes out to that part of our community, and look forward to seeing what we can do to kind of address that proactively while we try to not react, but respond to the current conditions. Thank you, Mayor.
Right on the second. Well done.
It was almost like it was planned.
Lindsay?
Thank you, Mayor, and thank you so much to all of you. I know how much work that went into this, and for taking that really seriously and doing a deep dive. This is one of the biggest concerns we have in our community. The mayor asked me right when I got appointed, what are your priorities? And I told her behavioral health, workforce development. This is why I'm here. This is what I want to talk about, and I want to try to coordinate and collaborate so that we can really try to make some significant changes. I do want to just shout out to our fire and our EPD. I mean, these co-responder programs are absolutely incredible. They're innovative. In particular, Chief Caven I'm looking at right now, with basically the same budget, you're restructuring and adding in mental health, really targeted medical services straight into the community. And this this is exactly why we need significant investment in that department, because that's going to impact our entire medical and mental health system overall. That being said, systematically and across the board, it is complex. Like you said, it's complex, it's chaotic. This little flyer right here, it says, we have no unified strategy to align and coordinate existing efforts, which are disparate and siloed. And I would, in my 15 years of experience in the behavioral health community here, including having worked on and been the contract holder for the Youth Mobile Crisis Unit at what was formerly the Child Center, and managing my own behavioral health nonprofit, I can say, sitting in the collaborative nonprofit consortium, the CBHC, every single director of nonprofits that are, providing behavioral health services are going to say the same two things. Rates are disproportionately, they're impacting our nonprofits because they're lower for our OHP clients, and private practitioners are getting a higher rate. So people are spending their time getting their certifications at our nonprofits, and when they actually have the experience to provide those services, they're going to private practice, usually reducing their caseload significantly. And two, we can't hire. We cannot hire. We can't hire. So I'm so excited to see our stabilization center and the inpatient, but where are we going to get those providers? So brings me to our workforce development. What can we do to address this gap? I know there's a ton of work being done, but it's all, it's not very we're not aware of it, right? And so I am definitely going to need a second round mirror. Thank you. I've got like so much more.
Okay, thank you. Matt and then Jennifer.
Thanks, Mayor. Gratitude to Eve and to Christy and to Ethan for the presentation, and deep respect and gratitude to our first responders, Cahoots and Whitebird personnel, and folks throughout the county apparatus, the mobile crisis units. I've told this story from the dais a couple years ago. I'll share it with you now for those who weren't here or need a recall. I called Cahoots because there was a woman who presumably was houseless, suffering presumably in a crisis, climbing the steps of a local church downtown, barefoot, swollen, barefoot, like she was in bad condition. So I called Cahoots and was told that they'd already been out there and there was no, the subject, the woman, the resident, didn't want the services. Is there any mechanism to compel an individual to seek help if they refuse Cahoots or the mobile crisis unit services, if they refuse their assistance and they're left on their own accord and are pretty clearly a danger to themselves or pretty clearly need some immediate assistance? And if not, from a judicial perspective, what can the city do to partner with the county or our nonprofits to advocate appropriately for the right tools to, and I'm going to preface this, like Councilor Groves and like Councilor Leach, I am enthusiastically looking forward to the erection of a behavioral day use stabilization center. But what tools can we give first responders, the mobile crisis units, Cahoots, to help those most in need who may or may not be able to make that decision on their own?
Yeah, this is a difficult, a challenging topic because there are really, of course, diverse opinions and then pretty firm laws on this topic. So behavioral health care is voluntary, and there are a couple of narrow exceptions. One is if you are an imminent threat to yourself or others, which is a pretty high-level definition of imminent. So someone who is in need and unable, apparently unable to make their own decisions about, on a cold night with bare feet, would not typically meet that definition of imminence in terms of civil commitment. There are other pathways for someone who, for example, has a mental health or cognitive disability that prevents them from making decisions that are in their own best interest. Guardianship is one of those pathways that can be pursued. That is not something that can be pursued in the immediate term. It is a legal process that you have to go through. And we have been really challenged. We have had patients of our community health centers who have been camping unable to remember to eat, and our staff bring them food. And to be able to go through the process of attempting to get to guardianship, also an extremely high bar. There was a committee at the state level called Commitment to Change that was commissioned by, I believe, the state legislature last session. They were meeting, trying to come to some recommendations about changing the requirements on the civil commitment system, maybe making it a little bit easier to move someone into the civil commitment system. My understanding is that work group is coming to finalizing their recommendations. They were not able to come to any consensus about where to go with our civil commitment laws in Oregon. I am not sure if any legislation this next session will come out of that, although I wouldn't be surprised if bills were introduced, and it would be good to track those.
Thank you. Next question is for Christy. You mentioned the, and by the way, thank you for all the stamped funded by the community safety payroll tax. I appreciate that. The Park Watch tool. What is the Park Watch tool? Is it an app? How can folks keeping score at home access the Park Watch tool?
You know what? I'm going to let our Public Works Director, Rich, come up and tell you about that.
If you, in the AIS, there's a link, and if you just go to the city's website and go to the search function, just type in Park Watch, it'll take you to, it's a web-based app that then people can report real time.
It is a web-based app. Okay, thank you. I tried finding it, and it took me to like a gas station. Okay. Okay, thank you. I appreciate that. 988, for those who are suffering suicidal tendencies. 211, for folks to get access to housing support services. Is there a need for a 3-digit number associated with mental health support in our community?
We are relying on 988 for that and are partnering with them to refer calls to us locally. We also have a crisis line that we run through Lane County. That is not a 3-digit number, but the 988 system in the state was, the decision was to centralize it, and there's lots of conversation about whether that's the best way to do it, but for now, that's the option that we have available.
Thank you. Finally, 47th in the nation is not good. How does the city of Eugene as an employer rank in regards to providing access to mental health services to our staff?
We'll have to get back to you on that number.
Yeah.
Okay, thank you. Jennifer and then Greg.
Thank you. So first, thanks to staff for coming today and presenting, and thank you so much, Eve, for spending your time and going through what is clearly a complex system and kind of trying to devolve it down into a short presentation. So I'm still processing, as I'm sure some of my colleagues are as well, and I'm looking forward to the next session where we talk about this more. And I just have one thing I just want to make sure I understand about our state in general. So it looks like we're putting more resources into our system. So our amount of resources is getting better as compared to the rest of our country progressively, but we still have a pretty high rate of folks living with mental illness. And I'm wondering if these statistics are, it looks like it's what, 49%? 49th in the country? Is that folks who are living with a mental illness who are not being treated, or just like everyone who's living with it?
What's the number, Counselor Ye, what's the number on that slide? If you could pull it on up, Jake. Is it on a page number at the
It's
bottom
on
there?
page 5, it's number 10.
Page 5? Can you pull that up?
Whether you're getting treatment or
So,
not.
one of the things related to the presentation, we pulled a lot of data from a lot of different sources. And so trying to ensure that there was consistency across all of those sources was a good faith effort. And so I would say that regarding what we were trying to establish is, here's this kind of a level set related to what the impact of the crisis is on the population nationally, at the state, and then at the county level, the city level, and then what funding is being available, and then how rankings are. And so a lot of times, I think we pull these things together for Councilor Zelenka's question of where do we sit comparatively across other states. And I think one of the big takeaways was that we're spending a good amount of money through OHA, and we're still struggling to get outcomes. And so is that an issue of, is there a need for more money? Probably. Is there a need for more workforce, more treatment beds? Yes. And then will we see changes? We believe so. You know, those are some of the results that we see when best practices are applied. And so I think that that's probably how I'd kind of approach that in that response. Does that help?
Yeah, it does. Yeah, I appreciate that. Oh, sure.
Counselor Ye, I was going to have Eve share some information related to other barriers to accessing services.
Sure, and to your question specifically, this is the state prevalence. Typically in epidemiology, when we use the word prevalence, that is just the population incidence of a condition. So this would be that we have a whole lot of people compared to other states who are experiencing mental health or substance abuse disorders. And my impression around the numbers on the investment in the behavioral health system and the outcomes that we're seeing is that we're playing catch up. So we had years and years and years and years, decades of disinvestment, and now all of a sudden we've realized that the house is on fire. And we're putting a bunch of money into a system that we haven't been able to build all the beds, we haven't been able to train and hire all the staff, and people have gotten so sick that it takes a whole lot more resources in order to stabilize them, rather than being able to catch people on the way up and prevent them from reaching that crisis inflection point. So because of all of this disinvestment, it is going to cost so much money to get us back into a kind of a rhythm where we have a healthy system and a healthy community. So that's not great news, but speaks to the intense needs in terms of access to care at all levels because of the crisis that we are in.
Okay, Greg.
Thanks, Mayor. I want to go back to slide 34 and looking at the deflection program. So I've heard over the last few weeks that there have been several meetings which potential providers have been invited to come and present possible programs or programming that will align itself with the deflection program. So a couple of questions here. First of all is, what are we looking at in terms of an overall budget for Lane County for deflection? And two, how are those providers being selected, and what standards or what assessments are being developed to determine whether those programs or those providers are successful, whether they, people, deflect away from the system because, they're getting treatment or they're, whatever the case may be, versus going into going in, like with drunk driving or substance abuse situations where the courts get involved, and then you turn around and you have not a deflection program but a diversion situation. So can you kind of summarize how we're looking at those three areas?
Sure. So in terms of the budget, I will need to get back to you since this isn't a program that's run out of Health and Human Services. I don't have everything off the top of my head the way I do in some other programs.
Who's running it, the state?
It's run out of parole and probation. Clint Riley, our former jail commander, is putting together the program. He's the project manager. But it is funded through the state. So, and also in terms of the providers, which providers are we working with? Most typically, that would be the Medicaid providers that are available in our community to provide substance abuse treatment services. And there are a number of outcome metrics. That's another one I'll need to follow up with Captain Riley to see if they have their full list of outcome metrics. Some of those are dictated by the state. Some of them we are creating as a local program in order to measure the impacts of our deflection program. And of course, every deflection program in the state is different. Every county got to pick to do it their own way. So we're going to have all of these pilot projects all over the state, collecting outcomes, comparing those outcomes to one another in order to determine which of these models appears to be the most successful in being able to deflect folks out of the system. For those who are not successful in deflection and they're re-engaging with the system, they will likely enter in, they will have charges filed, they may be booked into jail, and then they will go into a process where they may be diverted through our other processes, the treatment court processes that we have in place already. So deflection is just that first opportunity to move out of the system with treatment, and then diversion would come after if that is declined or if someone's not successful.
So if counties are designing their own deflection programs, which is what you just said, how do you determine the qualifications for the providers that are delivering those services in those programs?
So the deflection programs are hiring, our program is hiring a peer who's just navigating people to existing healthcare services. And there are processes already through licensing requirements and contracting and credentialing requirements with Medicaid as a major provider, but not the only provider. Certainly there's commercial insurance and Medicare contracting. And so the program is really relying on all of those systems, and licensing bodies in the state that are already determining the qualifications of the providers who are providing those services, and it's just navigating the individuals into the services. So the deflection program isn't responsible for setting anything up or determining the quality of care, aside from certainly if their outcomes demonstrate that one provider is doing better for them than another, that impacts referral patterns, which is what we see in healthcare more broadly.
Councilor Evans, I'd just add on what he was saying, in the AIS, so there's, the state provided Lane County $1.9 million to set up the deflection program, and on the bottom of page, I don't know, 6 or 7, it talks about the crimes or the offenses that would be able to go on into deflection. And then the last piece, and something that is for consideration, is that the OHA's agency recommended budget does not have deflection in it for the next biennium. And so I think that one of the questions is where is that going to land within the state budget, and what advocacy would be needed if this program is going to be on the back of a local provider, or if it's going to continue to be state funded.
So if it's not in the state budget, where's the 1.9 million going to come from?
Right, so I think that's as we look towards what our next steps and gathering more information about that could be something that is directed for advocacy in terms of funding, keeping funding flowing to deflection.
And I can speak to the dollars that have already come, were allocated in the short session. I don't know whether they came out of OHA or whether they came out of a different funding source, so I would have to research that.
Like the E-Board
Or Department of Corrections, or impacts funding. I would have to look and see which of all the funding options did those dollars flow out of.
Well, it would be helpful to know, A, where the money is going to come from, and B, how this program is going to be sustained over several bienniums, because when you start a new program, you got to figure out how to keep it going if it's successful. And my assumption is that this could be an alternative that will, provide a different path for folks that don't measure up to the level of being criminally incarcerated.
Thank you. I just want to thank you for that. It is 7 o'clock. I know that staff has to reconfigure this space for the 7:30 meeting. I have 3 counselors who want a second round, and I think, that we may just need to hold that until the next session. So hold those questions, don't lose track of them. And with that, I want to thank you very much. I think we all have a lot of burning questions about this, but the information you shared is really, really helpful for having a better handle on the larger context. So thank you all. And with that, we are adjourned.